I'm Dr. Steve Kurtzman. We're about to do a cesium implant on a 59-year-old man with a T1C Gleason score 3+3, PSA of 5, prostate cancer. So what we'll first do is position the probe, looking at the ultrasound, and I like to have the probe essentially straight, going up midline and going to the widest cut of the prostate, and then lock this down. So this is a real-time implant, so what we're going to do is we're going to contour the prostate from the base to the apex at 5mm intervals and then do a virtual implant. There's the first one at the base, and you can tell we're at the base. If you're looking at the ultrasound, when you tug on the balloon, you can see the balloon come in. If I come in another cut, that's all balloon. So right there is the top cut, so that's number one, Johnny. We're going to capture that on our Veriseed treatment planning system. Come back 5mm, that's 2, 3, 4, 5, 6, 7. So now what I'm going to do is I'm going to contour the gland so that we can come up with a three-dimensional reconstruction. So we contour the prostate, the urethra, and the rectum on each cut. Yeah, now we're getting down towards the apex. It gets a little bit more difficult to see, but you can see we're just contouring the entire gland. Now what I'm going to do is go back up to the base cut, contour the urethra on each cut. Okay, and go back now and we'll do the rectum. And obviously we're contouring these structures because we want to make sure that we're going to obviously treat the entire prostate, but we want to know our parameters for the urethra and the rectum as well. As far as the rectum goes, all I'm really interested in is the anterior rectal wall because I'm interested in the V100 to the rectal wall, which is predictive of complications. So I'm not interested in the entire volume. Some people look at the D30, whatever. I'm actually only interested in the rectal V100. Okay, now what we'll do is we're going to go and do our virtual seed implant. Okay, this was 7 cuts, so we know the length of this is roughly 3 centimeters because it's every half centimeter cuts. I'm going to use 12 needles around the periphery. I like to use an even number of needles. That way I can actually avoid the rectum a little better by offsetting them on the grid. And now what we're going to do is just go through and do a virtual seed implant. So I blow this up so I can see better. And I'm going to place the needles how I would ideally place them for a plan. So you can see I'm just placing these evenly spaced around the periphery of the gland. I've decided to use 5 needles on the interior, and this is a work in progress, so we can change this if we need to. And now what I'm going to do is go through and place seeds watching the isodose distribution that we're generating as we go. Okay, and I usually go to the base and the apex and place the seeds. And then I'll go around and I will start placing the seeds all throughout the volume of the prostate around the periphery, watching as we build an isodose distribution. And you can see the green line is the 100% isodose line, and we're building as we go. And we're starting to get very good coverage around the entire periphery of the gland, plus a margin. Good. I'm going to fine tune. Now, if you look at the parameters here on the screen, what I'm looking at is the prostate V150, the prostate D90, the urethral D30, and again the rectal V100. And I have it so that I'm flagged if I get hotter than I want. So in the D90 we're running a little hot. I tend to prefer to run these around 115 maximum. So I'm going to look and see where I'm cold. I'm a little cold here around the urethra, so I'm going to add one here, but we can get rid of somewhere. We'll get rid of this to get the D90 down a little bit. Yeah, good. So if we get rid of these, we'll still have good coverage around the gland. Actually, I can take these out now. Good. The dose is starting to break up, so we don't need a lot of these interior ones. I can get rid of a couple of these posterior. I still have good coverage on the gland, and I'm reducing my rectal dose. In fact, my rectal V100 is already down to 0. And now we have good coverage throughout the entire gland. I can actually move these down, the interior needles, and we have excellent coverage throughout the gland here. Good. So now what we're going to do is we're going to actually go place the needles as we go. And my physicist will actually match up the needle placement to where I physically place the needles on the ultrasound. Okay, Johnny. So what I do is I go to the widest cut of the gland. And we'll place the grid. The grid position is irrelevant for a real-time implant. Really what we're interested in is the anatomy of the gland. So I'm not paying any attention to the actual needle position. What I'm looking at is where are the needles within the prostate volume as I place these on the ultrasound. So I always start with my 2 posterior needles just off-center, again, to move the rectum. And that's a good placement right there. And I'm looking to have an even placement of the needles around the periphery of the gland. Okay, so there's my first 2 needle positions. And on the treatment planning computer, the physicist is actually tracking exactly where we're placing the needles and moving our needles to the actual position. So we'll go back and we'll recontour this with the needles in the actual positions. And again, we're going to have a true real-time dosimetric plan when we finish the case. Now I'm placing these very peripherally, and by placing these very peripherally, what we're going to do is we're going to get, of course, good coverage of the gland, but we're also going to push the dose to the extracapsular region. I tend to go side to side, that way I avoid torquing the prostate as I'm placing these. So I build it symmetrically. Good. Okay, last 2. Okay. Okay, good. So you can see the needles here are all placed pretty symmetrically, evenly spaced essentially around the widest cut of the gland. Now what we're going to do is we're going to go back and we're going to recapture everything. Again, this is something you can never do with a pre-plan, is we are now going to account for any changes that we actually made to the gland. Okay. That's probably number 1 right there. And that's 1, 2, 3, 4, 5, 6, 7. Great. Now what I'm going to do is I'm actually going to take my gloves off and recontour. I do all the planning myself. Some doctors like to have physicists do it. It's really just a matter of preference. But I like to actually sit down and do all the contouring myself. So you can see the gland has moved somewhat. And I'm going to change the position of the prostate. and the urethra, accounting for the exact changes that we made with this needle placement. And of course, the needles are going to be in the actual position because we watched real time and moved those needles to the correct positions as we placed them. Good. All right, so what I'm going to do now is go back to source placement and account for any of these changes that we made. Now I can move these interior needles because we actually have not physically placed them yet. Again, I'm looking to see the 100% isodose line cover the gland. So I'm going to add one here because we're a little cold anteriorly, but we have good coverage through the entire gland, very homogeneous implant. That's the nice thing about cesium, is that it gives us a very homogeneous implant, especially compared to palladium. You can see our needle positions are well matched up. I'm going to fine-tune these a little bit. You can see on the needle flashes here. And again, excellent coverage, good homogeneity, 100% isodose covering everything. Nowhere is the urethra receiving 150% of the dose. I'll keep that in there. And again, I can play with this dose distribution as I go through the implant. I'm going to add a couple here. I'm going to add one there because we're a little cold posteriorly. Again, good coverage throughout this entire gland. Good. I'm going to move these down just a bit because those are the interior needles. Good. And again, our parameters look good. So the D90 here is almost 110%, which is I usually tend to shoot between 100 and 115. Our V150 with cesium is only in the 33% range. That's fantastic, especially compared to palladium, where it'd be closer to 60. And our rectal V100 0.01 cc is receiving the full dose. As a matter of fact, I'm going to actually drop a seed right there. It still doesn't affect our rectal dose. And we have our implant. Now what we're going to do is we're going to go to a live view, go to the sagittal image, match it up with the ultrasound image, and we're going to drop the seeds, watching as we build our dose. So you can see here we've matched up our prostate volume on the ultrasound, corresponds extremely well to our three-dimensional reconstructed image on the treatment planning system. And what we're going to do is we're actually going to go drop the seeds and build the dose as we go, watching our parameters live as we build it. Okay. So the first needle we're going to go to is we tend to go posterior around in a clockwise fashion, getting the lowest needles that come into view. And you can see here, good. So we're lined up quite nicely on the treatment planning computer. We have our reconstructed image, and our seeds will tell us exactly how to place the seeds throughout the gland. Okay. We use a MIC applicator. I like a MIC because it gives us the freedom to drop the seeds individually. We can change things on the fly. And if I'm looking at the treatment planning computer, you can see that our volume is covered extremely well with the 100% isodose line. So this one's going to receive 4 seeds spaced evenly. Around the periphery, I always space them evenly. That's 1, 2, 3, 4. For those who don't use a MIC applicator, some people think it's complicated. It's actually a very, very easy skill to learn. Again, I like the MIC because it gives us the freedom to, as opposed to strands or preloaded needles, it gives us the freedom to change the implant on the fly if there's something we don't like. Next needle anteriorly. That's going to receive 3 seeds. And again, I always space these evenly on the periphery. 1, 2, 3. So we start at the base, of course, and then just pull back. I don't pay attention to clicks on the MIC because, again, I'm not interested in measurements so much as the anatomy of the gland, and I think that's a huge distinction to make. I think it's a mistake to worry about measurements rather than anatomy. Next one anteriorly. 3 again. 1. And again, if you look at the computer screen, you can see the isodose is covering our volume completely. 2, 3. Next one anteriorly. And I can see I'm a little outside the capsule there, so what I'm going to do is come down with this needle and readjust, something you really can't do with a pre-plan. But I'm right up against the capsule. My needle is right up against the base. You can see it tenting when I push on it. So I know I'm not in the bladder, because if I tug here, I can see. And this one's going to get 4. One, 2, 3, 4. Perfect. Now we're going to go posteriorly because this one's coming into view. Okay, I can see I'm well away from the rectum, but more importantly, I can look at my isodose curve on the computer, which is really what I care about. I don't care about measurements. I don't care about what hole I'm in the grid. Really what I care about is building my dose distribution, and I can see it on my treatment planning computer. This is going to get 4. 1, 2, 3, 4. You can see those spread spaced beautifully from the base to the apex. Let's come back anteriorly. Again, I'm right underneath the capsule here. You can see the balloon when I tug, so I know I'm right at the base of the gland looking on sagittal. This one's going to receive 5 seeds. 1, 2, 3, 4, 5. Perfect. Okay. Let's come, you can see the urethra here, so we know we're very far from the urethra. None of our needles are close. Let's actually get the most posterior one, midline. This one's going to get 4. And again, looking at my dose distribution, I can see that I've got the entire volume covered, and the rectum is receiving pretty much nothing as far as V100. 1, 2, 3, 4. Okay, back up top. How many? 4? I'm sorry? Okay, yeah. One, 2, 3, 4. Okay, stay anterior. 3 seeds. We can continuously check our parameters. So if I look at the treatment planning system, all my parameters as we build this are staying consistent. 1, 2, 3. Let's go. Let's just go post to ant. A little interference there. A little interference, but that's okay. How many? 4. One, 2, 3, 4. Okay, let's go to the next one, anterior. So I have a little interference, but I can see the base and the apex. That's all I'm really worried about. How many? 4. 3? Okay. 1, 2, 3. Okay, and then we're going to last needle on the periphery. How many? 3? 3 again. Good. One, 2, 3. Okay. Now what we're going to do is we're going to go back to the transverse image. Johnny, can you push that for me? Good. And we're going to go to the widest cut, and I can see on the ultrasound, you can see that. Good. You can see the seeds placed beautifully all the way around the periphery of the gland. So that's a very good looking implant. So now what I'm going to do is I'm going to execute exactly what I want to do. I need a total of 5 needles. So I'm going to place these seeds according to the plan. Just a little low. And we're going to match these up. So I'm basically hitting the targets on the computer screen, and that you can see that that's hit that first target. I usually start anteriorly. And again, I'm not paying any attention to the grid. I don't care what hole this is. I'm just worried I'm actually implanting the prostate, not a grid. So that's hitting the target exactly. And you can see the physicist is actually moving these to correspond to exactly where I'm placing these. So it's a true real-time implant. So this one, that's a little low. I'm going to come a hole up. Bingo. Right on target. So, unlike the peripheral needles, here I'm actually trying to stick to the plan. He's fine-tuning it, but we're coming as close as possible to what we planned. This one should be right about the midline. Come a hole up on that as well. Good. Excellent. Okay. Now we'll come back to the sagittal. Once again, I'm going to try to clear that little bit of interference that we're having. Good. Okay, that should do it. There's a little air in the rectum. Much better. Good. Okay. Now, we're going to go to the lower lateral one. Okay. That's going to get 3 seeds. Now, unlike the periphery where I space them evenly, I'm going to stick to the plan. So this one is going to get 1 at the base and 2 at the apex, because really what we're doing is capping off the ends. We're not looking to heat up the interior. That's always tends to be the hottest part of an implant anyway. So 1, I come back, 2, 3. Okay, anterior. Okay, 2 seeds. Now, it looks like we're a little bit cold at the base, so I'm going to ask Johnny to add a seed right near the base. Base. So all he has to do is right-click, add a seed. Good. I like that better, so we got better coverage here. And again, if you look at the lower right part of the computer, you can see our parameters are still all in the acceptable range. One, 2, 3. Okay, let's go to the midline needle. 3 seeds. Base, apex, apex. Perfect. One, 2, 3. Okay, let's go posterior. Okay, base, apex, apex. One, 2, 3. Last one. Up top. Now again, it looks a little cold to me, so I'm going to, and it may even be a little hot at the apex. We're going to move. Let's move that mid one towards the base rather than the apex. Good. I think that improves our dosimetry. Excellent. Okay, so this will be base, base, apex. One, 2, 3. And we are now done with the needle placement. So what we'll do next, we don't do cystoscopy, and again, placing the seeds on sagittal imaging it'd be very uncommon that you're going to end up with a seed in the bladder because you're watching exactly where you're placing. So we just do a dynamic cystogram looking for any seed movement, which again should be very uncommon. We just use some dilute contrast, usually two-thirds water, 1/3 contrast, because we don't want it so opaque that we wouldn't see the seeds, but we just want to see if there's any movement. So we're instilling the contrast, and you can see there's nothing moving. That's a beautiful looking implant. We got the base to the apex covered. Nothing in the bladder. We're done with the case. You can see it took about 20-25 minutes. One of the criticisms of real-time implants is that they tend to take a long time, just like anything else. Once you get proficient at this, it really shouldn't take much more than 20 to 30 minutes per case. I think the advantages of being able to change the implant on the fly and implanting the anatomy is crucial. I think sticking to planning via a grid leads to the possibilities that you could have systemic errors. Visualizing and placing the seeds anatomically, to me, makes far more sense for doing an implant. I'm Dr. Stephen Kurtzman. We're going to be doing a definitive cesium-131 seed implantation on a 63-year-old man with a Gleason score 3+3, stage T1C, prostate cancer with a presenting PSA of 5.6. We do a pure, real-time, intraoperative planned implant. So what we do is we do all our contouring and our dosimetry intraoperatively. We start, of course, by setting the probe. I like to set the probe straight up and down the midline, usually level or maybe even slightly angled anteriorly. And I start at the widest portion of the gland to make sure I have good excursion. And then what I do is I go at 5 mm intervals craniocaudally. And I identify the base. And you can see if I come one cut up, looking at the ultrasound, I'm at balloon. So there's my first cut at the base. And what we'll do is we'll capture this on our treatment planning system every 5 mm. So that's capture number 1. Cut 2, 3, 4, 5, 6. That's all. So after capturing the image, what I'll do is I go to the treatment planning computer and I do all our contouring to create a 3-dimensional reconstruction of the prostate, the urethra, and the rectum. Because, of course, when we're looking at our dose parameters, those are the 3 critical structures that we're interested in. And I can fine-tune this. See, I add a little extra there. So I want to be as accurate as possible when I'm contouring. The contouring, as you can see, generally only takes, probably less than a couple minutes. It's a very efficient procedure. So that's all 6 cuts of prostate, and I'll go back and I'll contour the urethra. And the beauty of this, of course, is that we are doing the actual anatomy in real time. So we're not worried about grid positions, we're not worried about the ultrasound position, because we're going to do our implant with everything as we've set it up versus trying to set up everything as the implant was planned, which I think is a much harder goal to achieve. Once we've contoured, what I do is I go to the treatment planning system and we're going to do a sort of a mock plan. Give me the number of needles that I'm going to use, and then I'll go through and I'll sort of customize the entire thing. This is a very small gland. I can tell what I'm going to use. I'm going to use 10 needles around the periphery, which is very little, but this gland is quite small. And I will use 4 needles on the interior. And we'll see how that works out. I may change this as we work out the plan. And again, that's the beauty of this. If there's a more optimal way to plan this, we can just do this on the fly. But I think I can tell already that 10 needles spaced evenly around the periphery and 4 needles placed internally, which are really going to just cap off the base and the apex. I suspect that this is going to work quite well. So what we're going to do is usually I go to the base and the apex first, and I'll add seeds, looking at my seed count and my dose distribution. And then I will start placing all my peripheral seeds. So what I'm doing here is I'm placing my seeds in all the needles that are within the gland. And I'm watching my dose parameters here on the computer as I go. So my D90 right now is 109 almost. My V150 at this point is only 36.9. My urethral D30 is very low, 1.108, and my rectal V100 is negligible, is actually 0. Good. Now I want to make sure that I keep this as homogeneous as possible. And you can see here what I have is I have excellent coverage. 100% isodose curve is the green line covering the gland. I have very little V150, which is represented by the red isodose lines. Nowhere is the urethra receiving 100% of the dose. I'm a little cold on this edge, so what I'm going to do is add that, and that actually pushes out our dose. I like to run my prostate D90 between 100 and 115%, and you can see I'm right there, usually towards 115%, because with edema, obviously, it'll be a little bit colder. And there I have sort of my virtual idealized implant. Now what I'm going to do is I'm actually going to go place the needles, and as I place the needles, my physicist is going to track along with me, and again, in real time, he is going to place the needles within the prostate volume as we build our implant, and we can fine-tune this afterwards. So what I do is I go to the widest cut, just like I planned it. Place the grid on. Now our grid is essentially a needle holder. I am not interested in grid positions because I'm implanting the gland. I'm only interested in where the needles are placed within the gland. So I don't care at all about what position within the grid it is. I'm going to watch on the ultrasound where I'm placing this. So again, essentially I think the template I think is nothing more than a needle holder. As opposed to a pre-plan where people are sort of slavishly locked into a grid position. So what I do is I usually start posteriorly, and I tend to start just off the rectum. I like to place my two posterior needles lateral to where you see the apex of the rectum. That reduces the rectal dose a little bit. And what I'm going to do is I'm going to go through and I'm going to place these essentially evenly spaced. This is a very small gland again, so I'm only going to use 10 needles around the periphery. That is a relatively low number. Usually that's somewhere between 12 and 16, but for very small glands all I need is 10. And as I place these, as you can see on the computer, which has the overlying three-dimensional reconstructed prostate on the ultrasound image, my physicist is actually tracking exactly where I'm placing these needles, which is then going to let us go back, recontour this to account for any changes, and we will have the exact needle positions. So there's really no guesswork. There's no uncertainty about the position of the needles relative to the prostate, because in real time we're going to account for any possible changes. I tend to build the implant symmetrically to avoid any torquing of the gland. I'm reaching my finger around the grid here. I can nudge the needle position. I'm not locked into sticking to a hole and going straight in. because I'm going to account for any of the changes that are made. Okay. And these are my final 2 needles. Good. Excellent. So looking at this image, you can see the needles are actually placed very symmetrically around the gland. What I'm going to do now is I'm going to go back and recontour this, again counting for any changes. Okay, there's our first position at the base. 1, 2, 3, 4, 5, 6. Good. And what I'm going to do is I'm going to go sit down at the computer and recontour this. I tend to do all the contouring myself. Some physicians prefer to have their physicist do it. It's just a matter of preference. But again, the beauty of this real-time approach is that we can account for all these changes. And as you can see, this gland didn't move very much. Sometimes you'll see quite a bit of movement, but this gland actually did not move much at all with the needle placement. Good. What I do then is I go back to source placement, and now again, where the needles have been placed, you can see, as my physicist did, he matched up exactly where my needles are, which is going to eliminate any uncertainty as to what we're achieving dosimetrically. Now, we're a little bit cold here. I can move these internal needles because I have not placed them yet. And as a matter of fact, what I'm going to do is I'm going to change the plan a little bit. I'm actually going to put a 5th needle in for the internal, because I can see here I can get a better dose coverage. So again, I've got the entire base now covered with the 100% isodose line. And what I do is I just go through sequentially, looking exactly what I'm achieving. My D90 is a little bit hot. I don't think I need this internal one yet. So you can see the inhomogeneity is going away. I'm a little bit cold here. I'm going to add a seed to this posterior one. Again, I have good coverage. I'm a little bit cold there, so I'm going to add a seed there. Good. I think I can probably get rid of this internal one. Good. And our homogeneity is quite good here. These I can nudge down just a little bit. They're outside the gland, and it's going to get rid of that hot spot completely. Good. So my D90 is a little bit hotter than I normally would, which tends to happen on smaller glands. But with edema, this is when I do my postoperative dosimetry on day 0 later today, it'll actually look a bit colder due to the resolving edema. So what I'm going to do now is we go to what's called implant view, which is going to give us a overlay of our reconstructed volume on our ultrasound, and we are going to drop the seeds within the volume exactly according to the plan, and we're going to watch our dose distribution on the sagittal image. Again, this completely eliminates any uncertainty as to where we're placing seeds within the gland, and we're watching our isodose distributions. And you can see here that the volume is lining up quite nicely. So we're ready to drop seeds. Using the real-time approach, I use a MIC applicator, and the reason I like the MIC applicator, of course, is because it gives me complete freedom to build the implant, to change things on the fly. We're not locked into any type of plan because I'm going to place these seeds just according to how we built them on the ultrasound. We're going to go to the lateral needle here on the bottom. I put the posterior needles going clockwise, and I get the most posterior needles as I place them. And on sagittal imaging, I'm going to drop these seeds throughout the volume. I go to the base, and I can tell I'm at the base because I can see tenting as I push the needle. So I know exactly where I am within the volume. I'm going to start dropping the seeds. 1. I space these evenly along the sagittal length of the gland. 2, 3, 4. Again, placing these on sagittal imaging, there's no guesswork. I know exactly where my needle tip is. I don't have to fear that I'm in the bladder. We have ultimate control. Next one anteriorly. So again, I can see tenting. This is also going to get 4, and if I look on the computer, I can see again that the entire image on this portion of the sagittal is covered with a good margin by the 100% isodose line. 1, 2, 3, 4. Next needle. So let's stay anteriorly because the posterior one hasn't come into view yet. 4 again. Many people are sometimes intimidated by a MIC applicator. It actually is very, very easy to become proficient at it. Just takes a few cases. 1, 2, 3, 4. And again, by using a MIC, we can place the seeds exactly within the volume where we want. Okay, let's go posterior. So now the posterior most needle is coming into view. And again, I'm looking, I'm tenting. You can see the balloon in the bladder. And we know we're at the base. We're going to place these seeds sequentially. One, 2, 3, 4, 5. Good. We're going to go anterior. Most anterior needle. Great. It's going to get 4 seeds placed evenly. 1, 2, 3, 4. Okay. Next one, stay anterior. Good. And again, we can see our needle is positioned perfectly just inside the capsule of the gland. This will also get 4. One, 2, 3, 4. Okay, probably posterior, yes. Next one's the posterior needle. This one's going to get 5. Now on the MIC applicator, I'm not paying attention to the clicks or the measurements. Again, I'm looking at the isodose distribution that we're generating as we place these. 1, 2, 3, 4, 5. Good. Okay. Let's go anterior. 4. One, 2, 3, 4. Stay anterior. 3. 1, 2, 3. Okay, and the last peripheral needle. 4. Good. One, 2, 3, 4. Okay. So we've completed the peripheral needle placement. Now what we're going to do is we're going to go place the interior needles. And we're going to go back to the transverse image. And I'll go to the widest cut. And unlike the periphery where I actually placed the needles and we dragged it to the positions, this time I'm going to actually hit the target because, again, we planned this implant according to interior ones were placed. So I'm going to be looking at the ultrasound image on the computer screen and trying to hit those needle placements. Good. So I'm starting on the upper left, and you can see my needle flash is pretty much identical to where my planned needle placement is. Again, my physicist is going to account for the slight changes that we make as we place these. Good. So again, that's hitting that target. Again, you can see I'm not interested in the whole position. I'm just interested in the anatomy of where I'm placing it. And I think that's a very important point. Good. And I'm going to need one more needle.
One more.
Yeah, so it's a little bit of an adjustment, I guess. We obviously can tell we don't know how many needles we're going to use. We don't even know exactly how many seeds we're going to use until we do our planning. But that's not a problem. What I do is we do a preoperative study in order to gauge. And in this case, our preoperative study was exact. We ordered 50 seeds, and we're using 50 seeds. In general, with this procedure, we do tend to usually have anywhere between 5 and 10 extra seeds left over potentially. Good. So now we're essentially going to go drop the seeds identically to what we did on the peripheral, watching our isodose distributions. Let's start at the lower left. Good. This is going to receive 2 seeds. Now these interior needles are essentially almost always dropping seeds at just the base and the apex, because the interior is always heated up by the peripheral placement, but we're really capping off the ends of the gland. 1. So it tends to be much fewer seeds and usually distributed at the base and the apex. 2. Let's go anterior. 2 again. 2 seeds again, base, apex. 1, 2. Okay, let's do the midline. Just 1 at the base. Good. You can see I just adjusted that needle placement slightly posteriorly because it was a little close to the urethra. And again, that's the beauty of doing this real time, is you can see all your structures as you're placing your seeds. 1. Okay, let's go to posterior. 2 seeds again. 1, 2. Last needle. Base apex. Yeah, so this happened to be all base apex. 1 and 1. That's fine. Okay. 1. And move back to the apex. Now we're going to just switch cartridges because there was only 1 seed in there. And just simple as doing a handoff and placing this back in the mic. 2, and we are now done with the implant. So you can see the entire process from planning through distributing the entire seeds took about 20-25 minutes, which is pretty typical. So one of the criticisms of real-time implanting is that people fear that it takes a long time in the OR. But once you get proficient at it, it actually is as short as any pre-planned technique, to tell you the truth. So what we'll do now is we don't do a cystoscopy, we do a dynamic cystogram, looking to see if there's any seeds in the bladder. If we instill dilute contrast and nothing's moving, we obviously know there's nothing in the bladder. So we're instilling contrast, and we can see nothing is moving. It looks like the seeds are distributed quite well. That's the beauty of a real-time implant. Again, the technique lends itself to placing the seeds very accurately, and I think we've accomplished that. We're able to finish this implant in about 20-25 minutes. 2 things I think are important. Number 1, the real-time technique is very efficient, and it gives me quite a bit of confidence that we've achieved our dosimetric goals intraoperatively. Cesium itself actually aids the planning. The higher energy really allows us to have a much more homogeneous dose distribution. We tend to use less seeds as well, which also kind of speeds up the efficiency. So I think the real-time technique really lends itself to pretty much achieving successful implants every single time through.